All right, we're officially on record here, so anything you say can be admissible in court later, I guess. All right, everybody, we'll wait one more minute, then we'll go ahead and get started. I see we still have some more people joining the session, so bear with us just a minute. Hey, Beth, what do you think? You ready to get started?
I was just thinking about how quiet it got once we hit record. Yeah, I say let's do it.
Okay, excellent. Thank you. All right, everybody. Thank you for joining us today for our session on telehealth advocacy. Probably no surprise if you're joining this session, you know that in the last 6 months, telehealth has become an incredibly popular topic. And as we kind of thought about this session, for the last, several weeks, one thing I thought about was, one comment, my boss made is, we hit the high point of COVID was he said, never waste a good crisis. So I'm sure that most of you, I know definitely our panelists that are involved in this session today would agree that, as a result of what's been going on with COVID, while, in a lot of cases, not a very positive thing, one positive thing that has come out of this is many of us have been fighting in a lot of cases for decades to try and get greater adoption of telehealth in the healthcare space. So I guess if you look at the silver lining, that's what kind of has come out of this is we have been forced out of necessity to do a little bit more, a lot more in this space. So very excited today for those of you that have joined us to talk about our topic. And hopefully you find it adds a lot of value for you. So we'll go to the next slide. All right. So again, welcome. Thank you all for joining us. My name is Dave Lingerfelt. I am the president of the Greater Kansas City HIMSS chapter, and it's an honor to be with all of you today. My co-host for this event is Beth Gall, who is the board member over our programming position. And she carries a lot of the weight here in terms of actually helping to set up these events, working with our membership, working with our various sponsors and stakeholders to determine, what the relevant topics are. And as we met as a board, about a month ago and started thinking about what would be the next event to talk about, normally this involves a ton of back and forth discussion. And this was a pretty quick decision that, we have heard a lot from our membership around tell us what's going on with telehealth. So very excited to bring this topic to you today. So next slide, please. I would be remiss if I didn't take some time to thank our sponsor for this event, Salesforce. Colt Hubbard, who's with us today, was very gracious to offer up, their platform to be able to host this session. While we are an organization that focuses on technology in healthcare, we still do very much enjoy the opportunity to get together with everybody face to face, to have that opportunity to network, to get to interact with each other. Clearly in current times, we don't get that opportunity. So, Colt and his organization has been a longtime supporter and sponsor of the Greater Kansas City HIMSS chapter. So we're very thankful for him and Salesforce for being able to bring this event forward today and allow us to use his platform to host this. We are recording this, so we'll be able to share this out. If you aren't able to join us real time, or as we know in the world of healthcare IT, if your work takes you away and you need to leave early, hopefully you can circle back and pick up what you might miss. Okay. Also, it's very important that we call out. I like to say it takes a village. And for those of you that aren't super familiar with the Greater Kansas City HIMSS organization or the bigger picture HIMSS national organization, it's important to call out that this is a membership/volunteer organization. So we all come together and work really hard to try and represent our membership, to bring education events forward to everybody, and add value to the Kansas City area in the space of healthcare IT. And what you have in front of you here is all of the individuals that work incredibly hard to ensure that all of this comes together for us. So all of these individuals donate their time. Many of them have been with the HIMSS organization for a long time as members. Many of them have been with us for a long time as board members, contributing their time and working with all of you to ensure we provide relevant information to help advocate and foster the health IT space in Kansas City forward. All right, at this point, it's my pleasure to turn it over to Beth, who's going to introduce our speakers. We have a really great lineup for you today. We have representatives across several of the major health systems across the Kansas City metro area, people that have been involved with this well beyond the pandemic, that have a lot of experience in this space. They became incredibly even more popular people as we started to move through this in the February, March timeframe. So with that, I'm going to go ahead and turn it over to Beth. And again, thank you all for joining today. It's a privilege to have you all with us.
Thank you, Dave. Yeah, we're so excited to have you guys in this discussion. Obviously, telehealth is something that everyone's talking about right now. We're all using it. It's a part of daily discussion. So let's go left to right and do some quick introductions. Jamie, would you kick things off, please?
Sure. I'm the System Director of Performance Excellence for Revenue Cycle at the University of Kansas Health System. And I've been the Advocacy Chair this is my second year, and I really like doing it.
I'm Denton Shanks, a family medicine physician at University of Kansas Health System. Assistant professor working with our family medicine residents and really students across multiple different professions. And then our medical director for innovation, virtual care, and digital health, and then a member of the HIMSS board. Very happy to be here.
Good afternoon. I'm Taylor. I am the manager of procurement and project delivery at Advent Health. And in my previous role, I was the trainer for our EMR for our medical group.
Hi, this is Melissa Abernathy. I'm the Director of Physician Revenue Cycle with St. Luke's Health System. Excited to be here with you all today. Thank you for the invite.
Thank you all so much. So without further ado, we're going to kick things off and just share a little bit about where telehealth was pre-COVID and what's changed for you all within the last 6 months. Taylor, can you start with Advent Health and share a little bit about what you guys have gone through?
Sure. So pre-COVID, we didn't really have telehealth. We didn't have a telehealth strategy that would be implemented anytime soon. Pretty much what Dave was talking about earlier, the strategy was much more long-term and had a rural focus. So it wasn't going to be anything implemented at our local facility for some time. So prior to COVID, like I said, we didn't have a strategy, but as soon as COVID did hit, we did have to pivot very quickly and identify how we were going to facilitate visits virtually.
Jamie, what did you see on your end?
We had a very strong plan, but it was more longer term. We did have some telehealth with some of our extended sites and got some reimbursements from some of our collaboratives, but not from payers. And so it's been an interesting shift. And Denton, I'm sure you can jump in on the clinical side in our experience.
Yeah, really at University of Kansas, we've got both the health system and the university side. And so university really says they've been doing telehealth for 20, 25 or more years and has been really innovative in it, but they've really been a lot more grant-based, and so it's not necessarily a full business strategy to move forward, but they get a great grant for different aspects of telehealth, telebehavioral health, and are able to fulfill that grant. On the university or on the health system side, we were developing a plan that we would then implement. Really, over the last year to 2 years, we were developing a plan that we would implement over the next 2 to 3 years plus. And so it was really that once all of this hit, and about a week in, we made a decision that we need to implement that plan now. And we really implemented that 2 to 3 year strategy that we were developing over the next week. And so really rushed to bring everything forward, and I'm sure all health systems kind of felt the same.
Yeah, Melissa, anything to add to that?
Similar for St. Luke's, we had been providing telemed services from hospital to hospital with various specialties for quite some time. We did not have a strong video visit presence, and we were getting some reimbursement because the payers were not on board for the most part. And as stated, we brought our telehealth up in just a little over a week and got with the payers. And I can speak more to that later, but yeah.
Well, I'm saying since we're talking about the payer side right now, just the challenges that you guys have faced at St. Luke's, what's the biggest hurdle that you've had to overcome to make this work?
Well, there hasn't been just one hurdle, I will tell you that. You know, just to bullet it out, you have the hurdle of the payers, you have the hurdle of the technology, really on both our facility side, getting it stood up, which was probably the easiest hurdle to overcome. And the biggest one, I would say, is just getting the patient familiar with the technology, how to move through it independently. And then ever-changing payer policies. I am just going to guess that the other revenue cycle folks on the panel and in the audience saw changes every day. And I used to start my day with coffee, and I started with payer policies for probably 6 weeks before it started slowing down a bit. And they're still deciding how they want to pay for these visits. So those are some of the hurdles.
And you saw the smile.
But we've overcome them. We're over them for the most part.
I'm so sorry, guys. This is where I have the dog and the kids come in and all that. So sorry.
Melissa,
would you mind taking over for a minute?
Melissa, I was going to ask you a question. For going forward, has any of the payers, have they given you any stop dates, or are they just continuing to extend right now?
For the video, we have all extensions from all payers. We've had 2 different stop dates. If I recall, one was like the end of June. Right now we're watching for the end of October. Some have extended through the end of the year. And of course, Medicare has us through the end of the year, but we are watching those, and we've seen some extensions and are expecting more.
And are you guys getting technical reimbursement for telehealth right now?
I'm on the professional billing side, so I hate to speak to that. I'm just not sure.
Okay, I'm back. So sorry about that. Taylor, I'd love to hear your perspective with Advent Health, just being that you guys are more than just in our region. What does that change look like for you guys? What does now look like compared to 6 months ago?
I think now we've really taken advantage of the technology available and made ourselves more competitive in this market. As mentioned earlier, other organizations like St. Luke's and KU are already doing this, and we weren't. So I think we've definitely brought ourselves, at least in this area, into the market. And now we have greater access. So we are offering several things. We're offering like touchless registration. We're offering the ability to text the office back and forth regarding your visit. It's just been a big change for our patients, and I think they're really happy to have options that did not exist 6 months ago, 7 months ago.
Taylor, you're talking about the Kansas City region, or where all is Advent Health? What's the total?
Sure. So Advent Health is a really large hospital system. So we are based in Orlando, but we have hospitals in North Carolina, Texas, Kansas, Illinois, and Wisconsin. And I'm sure I'm missing a couple states, California as well. So we're spread across the country.
Did any of them have a telehealth plan or strategy kind of?
No, not initially. The end goal was to have increased access across the organization and to have at least more touch points in states that maybe we didn't currently reside in. So it wasn't really a strategy that we were planning to implement anytime soon. It was definitely down the road, and it was going to start small with our rural practices and then work its way to our bigger facilities.
Now that has changed?
Yes. Definitely gone backwards.
I think a testament to that, too, is that you didn't used to be in this role. You came from a training background. Is that correct?
Yeah. So in my previous role, I worked for our physicians group as the trainer. And so when COVID did hit, somehow I became responsible for our telehealth strategy, which was a great opportunity for me. But I worked with our medical directors to identify what platform will we use. Because at the time, like I said, we didn't have one. And it wasn't like it was embedded in our EMR quite yet. So we started off with Zoom. And then once we realized the security parameters that we needed to be in, we then were able to get something set up very quickly within Athena so that we were able to have our visits within the EMR, and it was much more secure. But it took a lot of legwork, and I built a playbook around it, and it was a good learning experience, I would say, overall.
Very cool. Jamie and Denton, if you guys could share a little bit from KU Health side, I mean, what biggest challenges have you guys faced throughout all of this?
Denton, I think from just making sure we're going to get reimbursed has been our biggest struggle. The technology, I feel like, was a barrier in some aspects, but we basically put all efforts in the health system stopped to make telehealth happen in a week, and then we had to go back and do the integration like Advent did. And we really put a ton of focus on just making the experience better for the patient every time. And then I think Denton, I talked to him, I feel like every day for hours and hours and hours, and he spent hundreds of hours talking to providers into wanting to use telehealth. So that's one of the reasons we're focused at that goal for us.
So I had complete faith that Jamie was going to be able to get all of the reimbursements in the past, in the future, forever. And so I get to not worry about that. But then, really the adoption, we of course, we have this telehealth plan to kind of start going strategy for the next 2 or 3 years, and we implemented that really on day one after the week we decided we were moving forward. And so our strategy was to pull in Zoom as our telehealth vendor and to integrate that within Epic. But we quickly decided that really we need access now. Our patients need access now. We don't really have time to integrate it. So we developed health system wide, from the trainers to the IT to the administrators, everyone kind of coming together and formed a plan where we were able to schedule things inside of Zoom and inside of Epic, and then push that to the patient and get them connected. We went from BC, from before COVID, seeing about 5 patients in video chat per week. And then basically the first week of going live with our telehealth, we saw, I think, 80 on the first day, 200 or 300 on the second day. And by the end of the first week, we're up to maybe 800 or 900 and up to nearly to 2,000 a day for a little while as we move forward. So that quick ramp up period, but that was unintegrated with Zoom and Epic separate. And so about 2 weeks in from doing that, we decided that we really, now is the time to integrate the two. So while we were still running the previous unintegrated system, we then started building the integrated system, and Epic had told us it would take maybe 3 months or something. And we said we really need to do it within the next 2 weeks. And so we were flying a plane, building a plane, flying a new plane, remodeling the plane, all of that kind of at once. And so it really involved, full hands on deck, everyone active. We had phone calls until 2, 3 in the morning. It was also great. We had implemented Microsoft Teams at that time. So we just had Teams chat sessions going on at all different times. And once we got it built, then we really had to train the patients, the staff, the nurses, all of the different clinical workflows. And so that was a kind of another huge, big step, is getting everyone trained very quickly.
Denton, you've been such an advocate for telehealth since I've known you, just being a part of the board. What has changed, maybe not changed, how are other providers handling this that maybe weren't on the telehealth train to begin with?
Yeah, for the most part, I'd say that a lot of the holdouts have found reasons why telehealth is extremely beneficial in different spaces. And so there definitely have been some holdouts that say, my patients don't know how to do telehealth and they don't want to learn, or I don't know how to use technology and don't want to learn. But overall, I think that it's really that doing one virtual care, one telehealth event, one telehealth, and once you do that, you realize how easy it can be. And once you get the patient connected once, then it's so much easier to get them connected the other times. And so we really have had health system-wide, from primary care to specialists to our urgent care telehealth now, and actually inpatient telehealth now. And so really health system-wide, we've been able to ramp up different aspects of telehealth.
That's awesome. Anyone else have anything to add with working with physicians through this? How are other physicians handling the telehealth changes?
Our provider standpoint, I would say like 95% of them were on board because they understood the why. I would say 5% really did not want to do it, whether it was due to technology or assume their patient population wouldn't do well. But actually, our older patients did a really great job with navigating telehealth. And I would also say the majority were also concerned about reimbursement, because we had so many things changing every day, like how they needed to document in their notes what needed to be done. I found every day we were changing templates to make sure that we could get reimbursed for those visits. So those were the major things: reimbursement and technology.
Melissa looks like she's going to say something.
I have to concur with Taylor. You know, we had some specialty groups that were surprised by our patients. They outdid themselves, and there were some beliefs on, certain patients wouldn't be able to do things, and so there was some slow to the uptake. Overall, there was a lot of buy-in, but as our patients proved that they could, launch these visits, and we helped them along the way, the patients, that is, well, the patients and the providers. So I just have to concur with her statements.
I was just reading. I'm sorry.
Go ahead.
I was just going to say, so many grandparents are FaceTiming their grandchildren now. I mean, that's something that, I don't know that you guys, my parents are no longer just showing their forehead. Actually, I can see their whole face on a FaceTime now.
Yeah, we've seen, the littlest babies and their families to over 100 years old, all different, kinds of people. We've got a great family doctor, Dr. Lee Master, sees a lot of Nepali-speaking patients, Nepalese, and has been been amazed that he's actually been able to connect a lot with them with telehealth. Our MyChart, our patient portal, is now in English and Spanish, but not Nepalese, and so he's been able to work around that, but still amazed they all have a smart device and either themselves, or right now we're all quarantining together, so with the help of any of the family members are able to get on and join visits. And so really once you do that first visit, then it's easy to continue and follow up and do more. So many of our patients have appreciated not having to drive across town, across the state.
That's right.
Walk across campus, find parking somewhere, sit in a room with other people. be roomed over a period of time. All of this is basically eliminated and able to sit on their couch with their dog in their lap and have an amazing encounter with their care provider. So.
And at St. Luke's, I think it's important that we share even what our telehealth footprint looked like almost overnight, if you will. We were already doing telehealth in the hospitals, but we not only expanded to video visits, but to nursing homes. And so with our nursing home population, we worked with some of those nursing homes and we got iPads in place and that type of technology for that patient that was in a nursing home. And so we had assistance with the nurses to get those connected.
Takes the whole team. Taylor, I'm going to kick it back to you. What's next for you and your initiatives for telehealth at AdventHealth?
I think to continue to expand and see how we could explore some of those rural areas that we are kind of inching our way toward and opening practices in and getting more or increasing our access. I also think making our registration process easier. Right now we're using Freesia as our registration, but I do find that we need to make that a little bit easier, a little bit more streamlined for patients to understand. And then identifying new technologies that we can use to continue these types of visits. And also trying to incorporate those ancillary groups like our perinatology teams or our birth center classes, just a little one-offs that still have to utilize a hybrid of technology or a different platform, getting those in groups lumped in with the rest of us and having one option, I think, will be our future.
Melissa, how about for you? What's next?
We're looking at RPM, so remote patient monitoring, expanding there, expanding to just our POP health management, continuing to grow and explore options with other facilities and in the patient's home from the POP health perspective.
Jamie, I'm going to end with you so we can go towards the advocacy route. But Denton, what do you see on the horizon?
Yeah, I'm really looking at expanding our modalities of virtual care, whether it is video visits, telephone calls, instant chat messaging, asynchronous e-visits. I mean, really filling out that spectrum of different virtual care and then really increasing access to where really anyone that needs healthcare should have access. So many people have not accessed the healthcare system before, and it is scary just to schedule an appointment, or they haven't had insurance before, or they've had insurance for a long time, but they've been healthy and never needed to use it. And so giving people as frictionless access, and I think virtual care really does that, where you can quickly schedule a telehealth appointment. I've had many patients that really just schedule a video chat with me to meet and greet, and we chat and discuss their health and maybe answer a few of those questions that they've had about their health or something before, or about a family member's health. And being able to get your kind of foot in the healthcare door and start that, I think is really important. And then beyond that, I think also really important is care coordination. I think in-person visits, they came and maybe met with the nurse, were roomed, came in, I saw them or another provider saw them. Then they go to the checkout station, they do some checkout stuff, and then they're out the door. Now if we're in person, we have completely cut out the checkout station. And a lot of these are decreased, but we really need to look to virtual care to really pull in that care coordinating piece and following up with patients, making sure at the minimum that they got their labs done, any imaging referrals made, and a follow-up appointment. But there's really a ton more as we pull in our clinic. We really are interprofessional. We have a nutritionist, we have a diabetes educator, we've got a pharmacist, we've got a nurse care manager, and pulling all of them coordinatedly into this virtual care aspect is really, really important. And so furthering that development, I think, will be really important. But all of this hinges on reimbursement and business strategies and stuff like that. And so hopefully we all have a solution for that moving forward too.
Perfect segue to Jamie, who's going to discuss a little bit about advocacy.
I don't hear you, Matt.
Oh. Can you hear me now?
No. Anyone else here?
I can hear you.
Okay.
Me.
Sorry, Denton. Well, hopefully everyone else can hear me. I was just saying that's a perfect segue into advocacy. Jamie's going to share a little bit about what we can do. We've had this discussion as a board, and I asked her, I mean, I love telehealth. I have 4 small kids. I need that in my life. There's no way I can function without having access to our physicians. So how can we as not only patients but citizens be involved in helping to drive those discussions? So Jamie?
So there is a link that we're going to send out that people can fill out a little information about themselves, and it's really for this HR 7663 bill. And it's going to fix 2 of the issues for Medicare that we have right now with telehealth. The first one being Medicare really restricts telehealth services for reimbursement to rural communities. And this is going to expand those ability to get reimbursed for federally qualified health centers. And it will also include home as one of the originating sites. And the originating site is really where the patient physically is. So we can make sure we get paid for those services. It's kind of strange. It's an exclusion on historically. There's a lot of things we need to change about Medicare regulations to continue to grow into like a virtual hospital and get reimbursed the way Denton has my to-do list created. But I think that this is a right step in the right direction for HR 763. If we can get Medicare to say this is something we're going to do all the time and we're going to continue this, that will plow the way for payers to hopefully follow. They usually follow CMS, but sometimes they don't like to follow CMS. So those are the 2 issues that bill would fix. We still have some different things we need to work on. Part of it's the provider licensure. You have to be licensed where you're providing care, which means you have to be licensed in the state the patient is. If they're in a different state and they're getting a telehealth service, which can be an issue when you don't have licensure which connects to different states. So that's another thing we're going to have to continue to work on. And then Medicaid coverage and commercial payers. Medicaid obviously varies from state to state, and it depends on if that state decides they're going to reimburse for telehealth services. We talked about some of this stuff before, but some big barriers that we have to overcome as a nation if we want to continue to use telehealth and make patients happy. So here is how you can help us. There's a little link on here that you can fill out this little form, and it's going to go to support HR 7663. And then I included a link to look up your elected officials. If you want to give them a call, send them a letter, send them an email, tell them to support it. We want to continue to expand telehealth and use technology to support healthcare.
HIMSS National is currently doing a virtual march for this initiative. We will share this link with our LinkedIn network, our social media channels, but also we'll make sure to send out this slide deck so that everyone can look over. This is a lot of information, but this is a HIMSS National virtual march that we're all really excited to be a part of, and I'm going to make sure that you guys can join this. And you can sign up with this link even if you're not a current HIMSS chapter member. So feel free to share that with your networks as well.
All right. Yeah, on the reimbursement, I'd like everyone to kind of imagine, think about it in their mind, think about what we have always wanted to get with telehealth is really a one-to-one reimbursement, so it's equivalent to an in-person visit, whether you see the patient in person and you get whatever the reimbursement the payer or the health system, everything gets, or you see them virtually. And so really during this public health emergency, we have gotten to that one-to-one state. And that's what we've been verifying that all the different, both Medicare and Medicaid, but then all of the different individual payers are at that one-to-one state. Moving forward, a lot of them have granted our reimbursement and through the end of the year, and then it's all up in the air and trying to figure out what's next. And so all of these different bills and stuff like that. We've got a lot of people that imagine maybe down the road we'll get paid less for telehealth. You can imagine maybe telehealth is cheaper, or it's easier to see via telehealth, and it takes a lot of more resources to see via in-person. But really that will cast a future of telehealth where we're just barely trying to make it on to where we've really got to develop different business strategies to just make it. And so that's one. If let's just say we got paid 50% of an in-person visit, then really most of this will go away and we'll just find a few. Maybe we can afford having a nurse doing some video visits and we can find a business scenario where that works, or some other things. But really to be able to provide, for me as a primary care provider, a family physician, to be able to provide daily care or regular care to my patients, it just wouldn't be business financially viable if I only get reimbursed 50%. On the other hand, what I'd like everyone to really imagine is what if we got reimbursed 150%, if we got extra to go virtual first, and we actually got some extra money to do that, which was then to build out our virtual care platform, was there to really give access to all of rural Kansas, all of rural Missouri, inner city that currently doesn't have access. I mean, all kinds to build out the connectivity, all of these different issues. There's really a ton that we really need to build out. And if we actually strategized and came forward, we actually got more money for virtual care first. We were able to better provide better triage, bring people onto campus when they actually needed to be onto campus for a physical exam, for their labs, for their imaging, for other things, and bring them on and be very efficient with their time on campus, but then really did virtual care first for everything else, and we got reimbursed well for that, then really the sky's the limit. We'd really be able to innovate and provide huge access benefits to patients, provide better care, and actually provide better care when we see them in person. So I could talk for hours on that, but I'd really like everyone to kind of imagine that, and this doesn't have to just resort back to the old ways or the ways that things used to have been. But if we actually are able to push this forward, we can truly transform healthcare for our children, for everyone, for tons and tons of people that have not had access to care before. So I can keep going, but
I think it's a good point. And I also think, especially like with the drop in physicians for family practice and just the flexibility that it adds to physicians' lives, and they can still see patients and keep healthcare going, because I think that's the flexibility that it allows people to have and still provide care is really great.
Melissa, is there anything that you'd like to add? Oh, you're muted.
I would just echo things that have already been said, but it's imperative that we get it reimbursed. So that's in doing that, we need to make sure we're educating people to the benefits of telehealth, keeping them out of the hospital, improving chronic health, how the older population can benefit from this, not just the working moms with 4 kids, because it helps us a lot, right? But that older population and managing chronic disease. And there's a careful balance that we need to also make sure that we are educating, the public on, and that's when in-person care is needed.
That's a great point. Taylor, how about you? Anything else to add?
No, I think that everybody covered it really well.
Hey, Beth, I just one thing I would like to ask of the panelists, and selfishly, since, I don't think you can mute me. So I invited several of my healthcare IT students onto this call, as well as several of my med students. So these are students that are, either in clinical rotations or about to go out into residency and fellowship. So I'd love to ask, our panelists, Dr. Shanks, you're a practicing physician. So what advice do you have for, our med students getting ready to move into this field? And then also our other panelists, what advice do you have for our healthcare IT students around, what do they need to think about as they move forward into this industry, knowing that we're in new times and it's a new frontier?
Yeah, very much that this is not going away. We don't get this education really in med school. We don't traditionally. And now over the last year, we've actually now been reached out by many different med school groups and student groups and stuff like that on how to do it. We've got KU has the Bulldoc student-ran free medical clinic, and now they have to transition everything to telehealth. And so I was on the phone earlier today, and these are first and second year med students and beyond, but they've got to really grasp how do we do this. And so lots of great education. My number one advice really for everyone is to go out and have a telehealth your doctor, or telehealth your health system. Go out once you've had one appointment, even if today you're healthy, don't have any issues, but this winter it'll be cold, there'll be snow and ice, and you'll have a cold or something else, or a cold that complicates something else, and you'll really wish that you had jumped on and done one video visit with a doctor. So go establish care or follow up or something like that, and do one of them and make it easy to move forward. Yeah.
To Melissa, I didn't know if you saw that in the chat. We were asked about unemployment and high deductible plans and if we've seen an impact in balance collection. I'll say that we have seen an increase in need for financial assistance, and we're billing people if they can't pay their copay, but not denying care, and putting people on payment plans when able, and putting them through a financial clearance process to see if they qualify for Medicaid or another program as much as we possibly can. And I think flexibility has just been really the key in this for us.
For St. Luke's, a couple points there. We have not seen a big shift in our payer mix, so that's been nice. And the telehealth visits are still, for the most part, cost sharing waived, so it's been pretty good and healthy for our organization at a time of financial strain, because we're getting payment in full even on high deductible plans. Now, the exclusion to that is the self-funded plans that are embedded into the major payers, Blue, Aetna, and so forth. So it's not a one-size-fits-all where everything is waived, but those self-funded plans have a choice. But telehealth, the video visits have been cost-sharing waived by the major payers, at least with the most recent one set to expire at the end of October. We'll see if that happens. But it's actually been a benefit there for the patients and the high deductible patients, as well as the health system.
I saw an article just recently, I don't know, it's on my computer somewhere here, that really was talking about when ATMs and your banking all went virtual, and really there were certain bank accounts you could sign up for that was, please don't step in the bank ever again, do everything virtual, and you'll have fewer fees and stuff. And so I saw some article about whether it was insurance or a health system that was really putting forward a similar plan that was, we will allow you to have kind of unlimited or very frequent telehealth appointments, but then coming onto campus or something is going to be much more selective. And so I don't know if Jamie or someone on may have read the same article, but I think there's some very interesting aspects of a virtual care first plan or something like that. Jamie, you're on mute.
I have read that article. I do think it is a very interesting concept. I think you still need to have some in-person pieces for radiology and lab services and things like that. But I'll be interested to see what happens with plans this next year and as payers change. Hopefully their approach to make it easy for us.
I am not anti-in-person. I think absolutely you got to come in and have certain physical exams and stuff, but there's really a ton we can do with virtual care, especially as we spread it out and be able to instant chat with a nurse and then say, oh no, let's digital triage you and say, oh, yep, you really do need to be seen. Let's jump right into a video visit with a provider. And then me as the video visit provider could almost say, well, no, we really need to look at your arm. You fell. I don't know if it's broken or not. So walk down to the urgent care down the street and I'm prescribing you a physical exam at the urgent care. And so they'll take over and do it from there. And so that full spectrum of care, I think, will be very, very optimal going forward.
Yep.
Some discussion. Thank you guys so much. Dave, I'm going to kick this back over to you.
Beth, thank you to all of our panelists. I agree. I think we're in very exciting times. And as I heard all of you talking, I was kind of feverishly taking notes on some of your points, which are very warranted. And I think we do have to continue that work to flip the model, right? I think about, 6 months ago prior to this, I was trying to, use the portal to schedule a visit with my provider and, found there was no appointments for the next month. And I thought, well, there's no way unless this guy's left practice that this isn't possible. So I pick up the phone, I call, so effort on my part, someone answers the phone and I say, hey, I'm trying to get an appointment with my primary care. Oh yeah, he can see you tomorrow. And I said, well, why wasn't this available via the portal? Well, not all of our appointments are available via the portal. So of course, I put on my tech hat and go, that makes no sense at all. Well, I have to pick up the phone, waste my time, waste a live person's time on your side to schedule an appointment. This is absolutely ridiculous. Why do you want to do that? Let's incentivize us to use technology, blah, 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 right? So I think this is a very warranted discussion. So again, I can't thank you all enough for all of your time and contributing your wisdom to what we're doing here. This is clearly not the last discussion we'll have on this topic. And again, just kind of one last plug, for the legislation they put out there for you to, kind of share your thoughts. We're not trying to sway you to one political opinion or another. We're just trying to continue this advocacy for greater adoption of telehealth. And I don't think she could join us today, but one call that we had very early on in this pandemic was we convened some of the local CIOs here in the metro region and started to talk about how can HIMSS get together and help to help move this charge forward. And the consistent theme we got from the CIOs on the call was simply this: we have been forced to make dramatic strides moving forward around adoption of technology and telehealth. Whenever we look in the rearview mirror and see this pandemic is behind us, we cannot go backwards. So if you can do anything to help us out, it's continue to help advocate to move this forward. And I know I'm essentially, quote, preaching to the choir here, but this group understands the benefit we get of, being able to, treat patients without having to make that physical trek into the office. So minimizing our exposure and all of those things. So again, thank you very much for everybody that helped contribute to put this event together, our panelists and Beth for all the work, our board of directors. We'll send out an event survey afterwards. We would love to get all of your feedback. Again, this has been recorded. And most importantly, I look forward to a time, hopefully in the future, where we can all convene in person, because I'm looking at my clock right now. It's 10 minutes until 5. And normally I'd be standing in front of you sharing information about where we're all going to go have a cocktail afterwards. And instead, I'm sitting here with a sad bottle of water. So I look forward to that opportunity, hopefully very soon, where we can all get together to do that. But for now, thank you all for your time. I know you're incredibly busy individuals. All of us working in the field have been incredibly busy over the last 6 months. So thank you for all that you do. Keep marching forward, and I hope you all have a great afternoon, and I look forward to seeing you all at a future event.